So welcome to Grand Rounds for March 2021. Today we have Dr. Emily Getz talking to us about motivational interviewing. Dr. Getz earned her doctorate of physical therapy from Misericordia University and then promptly moved south to enjoy year-round sunshine and warmth. While practicing in South Carolina, she completed her orthopedic residency and obtained her board certification in orthopedic physical therapy. She completed a fellowship in orthopedic manual physical therapy and is now a fellow of the American Academy of Orthopedic Manual Physical Therapists. Dr. Getz's passions are teaching and mentoring, defining and improving on clinical excellence, and promotion of the PT profession. Dr. Getz is currently working toward a Doctor of Science in Physical Therapy to further those passions. So I'm going to now turn it over to Dr. Getz. Please make sure that you are logged in as your name, because that's how we mark attendance. And at the end of this, as soon as my e-learning processes this program, you'll be receiving an invitation to complete your the quiz and the course evaluation. Please do make sure that you complete both the quiz and the course evaluation. And as long as you're logged in already in Teams, you are logged in. All right. So
I don't think I get credit for it.
Please just make sure you are muted because this is being recorded. All right, so without further ado, I'm going to turn this over to Dr. Getz.
All right, hi everyone, and thanks Steve for that glowing introduction. Much better than I could have done myself. But we're going to talk today about motivational interviewing and how that can be applied in physical therapy. So this is just a little information about the continuing education credit that you will receive for viewing and participating in this lecture. Our designation statement and disclosure information. I have nothing to disclose. There's no financial relationships to disclose. So our objectives with going through this lecture are just to be able to define what motivational interviewing is and its core concepts. To be able to identify change talk within our patient interactions, start to apply some of these concepts of motivational interviewing within our patient interactions and really help to build therapeutic alliance, to compare motivational interviewing to some of our other interviewing styles, and select most appropriate interview style for patient interactions based on their presentation and clinical reasoning. So let's first talk a little bit about what is motivational interviewing. And we have this nice definition from Dr. Bill Miller that's saying that it's a directive, client-centered counseling style for eliciting behavior change and helping clients to explore and resolve ambivalence. So he really wants to stress that it's a guided approach. Patients, they always have good reasons to change their current behaviors, but they're really aware of both the benefits and the costs associated with changing and staying the same. So, that kind of think about patients, they want to get out of pain. They want to be able to do their activities, but on the other hand, there's definitely costs associated with it. Direct costs such as copay, co-insurance, and indirect costs as the time and effort that it requires to maybe go to their physical therapy sessions and then to complete their home program. So this is Bill Miller, Dr. William Miller, and he started his research career in Oregon and then continued to research when he was at University of New Mexico, and he focused really on problem drinking. And so when he was doing his research into motivational interviewing, he came out with this quote that I thought was pretty informative of what motivational interviewing is, and it really looks at to evoke defensiveness and counter argument. When we interview in a way that evokes defensiveness and counter argument, people are less likely to change. And so he set out to discover how he can counsel in a way that evokes people's own motivations for change and really taps in that instead of putting them on the defense. He wants to have the client, not the counselor, voice their reasons for change. So this is really the beginning of motivational interviewing as a very patient-centered form of counseling that helps patients reason through their goals and come to their own conclusions about what they need to do to change their behaviors. So the initial study that Dr. Miller did, and part of his dissertation, was to test 3 different behavior therapies to help problem drinkers change their alcohol use. And he found that the least as the most intrusive. And so there really wasn't any difference between counseling sessions that were really intrusive and then the counseling sessions that were less intrusive and more guided. And there was a really unexpected finding with a self-help guidebook that was distributed after the sessions are over. The guidebook was written by Miller and one of his colleagues in 1976. And within the study, they gave half of the participants the guidebook and half didn't get it. It was randomly chosen. They found those that did receive the guidebook continued to decrease their drinking right away versus those who didn't receive the guidebook made no changes. So he found this really interesting, and then he kind of developed a second follow-up study based on that. And so he looked at problem drinkers who had 10 counseling sessions versus 1 counseling session with the self-help guidebook. And he was really surprised to find that there was no difference between the groups for the reduction of drinking. And he repeated this study time and time again, and it all yielded the same results. They find that there was no difference between 10 sessions and 1 session with a self-help guidebook. He really felt that, when he reflected back on why this could be happening, felt that the critical piece was teaching the clients accurate empathy and skillful listening when trying to guide them to change their behaviors. So he continued to look into this and research it and did critical review of the studies, and he found that therapists that demonstrated the highest level of empathetic skill had the best results. Only a quarter of the patients working with therapists that showed less empathy had good outcomes, and they're actually able to predict 2/3 of the variation in the patient's drinking at 6 months, just based on how well the counselor listened to the patient. They went a little bit further than 6 months too, and they found that even at 1 year and 2 year follow-up, they could still predict how much patients would be drinking based on how much empathy that the counselor showed during their therapy sessions. And he really started to argue that behavior change is only possible when the patient or client felt personally accepted and valued. So then in 1983, he published a paper in the British Journal of Behavioral Psychotherapy titled Motivational Interviewing. And he said this paper was based largely on intuitive practices and reflection upon his previous research. And in 1988, so 5 years later, he partnered with Dr. Gail Banfield and developed this Drinkers Checkup, the DCU, and they brought it to the community. It was a low threshold brief intervention for problem drinkers, and they advised the community that it's a free checkup for drinkers who want to find out if their alcohol was harming them in any way. And they saw a huge response from the community, a huge turnout. After doing this DCU, 14% of the participants in the DCU sought help within 6 weeks of their feedback, but participants as a whole showed significant and immediate reduction in their drinking, and they retained this at 18 months as well. And so then they followed this first study up again with a second study to make sure that their findings were reproducible, and they had similar results. And overall, these results were unprecedented in this area of research. They had never really found that doing some brief intervention could change behaviors. So then Dr. Miller goes on sabbatical, and he meets this guy here, Steve Rollinick, and they start drinking or start chatting, and Dr. Miller really thinks that and really sees that Steve has the expertise to teach those skills of empathetic listening that's required for motivational interviewing. So the two of them together go ahead and publish their first book on motivational interviewing in 1991. They revised it in 2002. A third edition put out in 2013, and they're currently working on their fourth edition, expected in 2024. So something for everyone to mark their calendars and look forward to. So let's look at a little bit of research, a little bit of evidence for motivational interviewing, specifically in physical therapy practice. And so in 2020, we have a study that was done and a practical guide that was written for clinicians on using motivational interviewing with pain neuroscience education in our chronic pain population, just because we know that this can be a really tricky population to kind of make changes and move the needle on. So they tested motivational interviewing and PNE for this population, and they found that it was beneficial in the short term. They found that the motivational interviewing, because it's a patient-centered communication style, they were able to elicit and start to change some of the patient's behaviors, and then combining it with PNE, which we know to increase pain beliefs and knowledge, awareness, willingness, it really helped to open up some opportunities for this patient population. In 2016, we see a systematic review that included 7 RCTs and almost 1,000 participants with chronic pain again. They found there was a small to moderate overall effect if we use motivational interviewing in the short term, but unfortunately no long-term effect. And interestingly, they found that in patient populations with fibromyalgia, if they had the use of opioids and they were obese, there is really diminished effects of motivational interviewing. Since 1983, there have been over 200 clinical trials of the effectiveness of motivational interviewing, and we kind of all see the same a lot of short-term effects. And so then Frost in 2018 went back and did a systematic review of systematic reviews, including 104 systematic reviews on motivational interviewing and 39 meta-analysis. And again, he found moderate quality evidence for mainly short-term, less than 6 months change. So it's just a time to take pause and kind of consider, does this lack of research negate motivational interviewing as an appropriate treatment intervention, or is it still beneficial to incorporate this, knowing that it's mainly short-term changes? And one thing that Frost came out with his, or really stressed within his study, is that across the board, the research that he found was highly variable. And so can we really hang our hat on something that isn't consistent and easily reproducible? So something to think about. So let's get into specifically how to implement motivational interviewing inside of our clinical practice. And so there's 4 main processes inside of motivational interviewing, and these things occur at every motivational interviewing treatment session: engaging, focusing, evoking, and planning. So for engaging, we know every relationship begins with a period of engagement, and this is our time to really start to build therapeutic alliance with our patients. And therapeutic alliance is a term that we all throw around a lot, and it was first described by Freud in 1912. But the key to therapeutic alliance is being able to understand your patient and develop a trusting relationship in order to allow the delivery of interventions in a safe and healing environment. And I think it's important to really think about and consider the word healing there, something both physically healing for our patients, but we also want to make sure like they feel mentally safe and they can heal some of those other psychosocial things too. And so there's three things that are said to really improve therapeutic alliance, which is agreement on your goals or collaborative goal setting, agreement on interventions, shared decision making with your patients, and an effective bond between the patient and the therapist. And this is really that therapeutic relationship that we talk about a lot. For focusing, once we've engaged with the patient, we really need to figure out what their goals are. And this is something that Miller argues we need to develop really early on in this session. And so we want to find out why the patient is seeking out physical therapy and what is most important for them to accomplish. So I kind of put 3 goals that we hear fairly often within the clinic, and we want to think some goals are definitely better than others. To get out of pain is something all of our patients say, but it's not very specific. It's not necessarily, maybe a little bit of subjective measurability there, but things like that are more objective are things that tend to have a bigger impact within the clinical setting. So next we have evoking, and this is where we're trying to elicit the patient's own motivation for change. It's really the heart of motivational interviewing. We want to focus in on the particular issue or what the patient sees as the issue, what their goals are, and then we want to tap into the patient's own ideas about how they might be able to change. And for a lot of us, it's the exact opposite of what we do every day. The patient, we determine what the problem is, determine what the patient's doing wrong, and then we educate them on how to fix it. Right? We tell them what they need to do in order to get better. But for motivational interviewing, this is the exact opposite. And so when we're evoking, we're looking for something that Dr. Miller refers to as change talk. And so we see 6 major themes with change talk, and each one of these, oh, sorry, my bad. We can go into depth with each one of these. So for desires, we're looking at the patient's wants, likes, and desires. And so we'll hear things like, I would give anything to be able to blank, climb stairs, run, throw a baseball, that sort of thing. For ability, it's what the patient feels capable of doing. So they might say things like, you know, I can walk a mile every day after dinner. I might be able to manage that. So what do they feel like they have the ability to do? For reasons, they're really answering the question, why should I change my behavior? And so it's going to be something like, I want to teach my grandson how to throw a ball. I want to inspire my, sister to get healthy as well. Things like that are going to be good examples of reason change talk. For need, it's the patient's sense of what is needed and calls for a way for that need to be met. So you might hear things like, I guess I just need to make healthier choices. I know I need to get more sleep at night. I know I need to get more exercise. For commitment, it's a commitment by the patient to use some sense of action. And so they're going to say things like, I'm ready to start exercising more every day. You can count on me to do my home exercise program. And then from there, taking steps is actions taken by the patient in that direction of change. And so this is really important because the more patients talk about change, the more that change is strengthened and reinforced, and more likely that we'll actually see behavior change. And so after we evoke some sort of change in our patient, we need to start planning how we're going to achieve those goals. And so this is both developing commitment to change and formulating a plan of action. And Dr. Miller says it's really the clutch that engaged the engine of change talk. So just going back to change talk, these are some things that our patients might say, and then how we can transition that statement into a planning mindset and how we can start to plan. And so, we might hear a patient say something like, I can't go on this way. And so as the clinician, we can reflect on that and say, so you realize that it's time for you to try something different. And then we can follow that up. Where do you feel like you should begin? Or for a patient that says they've never felt this incapable, or they haven't always been this incapable, we can start to ask them about what they feel like their strengths are. So change talk is going to be any speech that favors movement in the direction of a healthy behavior change. We can also have sustained talk, which is the opposite. It's speech that's going to favor no movement or no behavior change. We want to be careful not to reinforce sustained talk. So we're going to get into the spirit of MI, and this is kind of what we need to think about when we're applying motivational interviewing within our treatment sessions. And so Again, it's a patient-centered counseling style for addressing common problems and trying to elicit change within our patients. It's really important to remember that it's done for or with someone. We're never doing this on or to them. We're never the ones going to be to fix the problem. And it's often described as the dance between the counselor and client, or in our case, the clinician and patient. And so there's 4 key aspects of the spirit of motivational interviewing, and we're going to go into each one of these. So collaboration, again, it's that dance between our client and counselor, or patient and clinician. And it's an active collaboration between 2 experts. And we say 2 experts because people are the undisputed expert on themselves. And to be able to get a patient to realize that can be really powerful. It can add a sense of value into what they're bringing to the treatment session. Like, you're the expert on you, and the only way this relationship is going to work is if you take on that role and you also pour into this treatment session. Acceptance. We have 4 aspects that we need to consider when we're providing acceptance to our patients. And so, absolute worth. Every human deserves worth and commitment to help. For empathy, we really want to make sure we're trying to see the world through the patient's eyes. For autonomy, we want to honor and respect each patient's autonomy, letting them lead the direction of change. And affirmation, we want to seek and acknowledge the patient's strengths and efforts that they're making towards change. For compassion, this is not pity, sorrow, or the need to suffer. It's really trying to promote the other's welfare and give priority to their needs. And when I think about compassion, it's really being an advocate for the best care. I want the best for them, and I want them to find that within themselves as well. And then we go into evoke. And so this is really educating the patient that they have what they need, and together we're going to find it. We're trying to evoke what's already present within the patient and try to dip into what they feel like needs to happen in order for a behavior change to occur. And so there's a couple different ways you can evoke a little bit more. And so we can ask about importance, such as on a scale of 0 to 10, how important is it for you to, for example, throw a baseball with your grandson? And so we kind of get them to dig into what is most important to them and put a number to that. And we can ask elaboration, like, what is it about throwing a baseball that's so important? Or why do you feel like that's going to help you bond with your grandson if that's what they've said to you? And then we can ask scaling questions about, like, why did you rate that activity as a 4 and not a 1? Or what would need to be different in order for you to feel like exercising more often is more important? So we have some guiding principles about how to start to apply it and within our treatment sessions. And there's a nice little letter template. I'm blanking on the word, but for us to remember these guiding principles. And the first one's going to be resisting the writing reflex, understanding the patient's own motivations for change, listening with empathy, and empowering the patient. So during a motivational interviewing session, the clinician is helping the patient to examine their own personal values about ambivalence and behavior change, and really supporting their self-efficacy and internal motivations for change. And so the first up is resisting the writing reflex. This is what tends to be the hardest thing for physical therapists, because we're trained to fix. We're trained to show the patients how to do the exercises, and we're trained to use manual therapy techniques to help them with their pain. And motivational interviewing really requires that we suppress that. So for most patients, they want to be fixed. And so we have to consider that when deciding whether motivational interviewing would be appropriate for them. For me, I find it to be most impactful for those patients that aren't progressing like I thought they would, or they've had physical therapy in the past and it's failed them. They haven't been able to achieve their goals. And they usually do the best with motivational interviewing. And this was just a nice little comic that I found. So the plumber is definitely listening with empathy and summarizing the problem for the woman, and she is regretting her decision to call him versus the Mr. Fix-It. The next thing we want to do is try to really understand the patient's own motivations, right? We want to see the world through their eyes and understand why they stated their goals to be what they are. And we want to make sure we're listening to understand and not listening to answer them. So we want to follow their lead. What's important and why isn't something important? What's driven this patient to seek care? And if the patient's resistant to change or using the sustained talk that we talked about earlier, don't argue with them and don't say, no, you need to see it this way. Just kind of follow their lead and try to really listen for change talk and focus in on that. So when we're listening, we want to listen with empathy. Effective listening skills are essential for this, and it's really a skill that takes time to develop, time and practice. As a general rule, we want to make sure we're spending equal time listening and talking, and something that can be really outside of our comfort zone, but really informative as to how well we're doing with this is just ask your patient if you can record, maybe the subjective portion of the evaluation and listen back on it and really reflect on how well you were listening empathetically, or if you were just listening to answer. Empower our patients. We know patient outcomes really improve when they are an active collaborator in their treatment. Empowering is really about letting them explore their own ideas on how they might be able to make change. Again, we're not the ones trying to fix them. We're trying to let them get to that answer on their own. And we're really drawing on their knowledge about what has succeeded in the past. And across the board, we know that allowing patients to be active collaborators or having a really collaborative relationship is a powerful motivator for our patients. When they're able to develop their goals with us, they know, okay, this is why we're doing this exercise. And then lastly, we're going to talk about some skills that they found that the most successful motivational interviewers utilize within their treatment session. And so we're looking at open-ended questions, affirmations, reflections, and summarize. And then there's a +1 because it's not something that occurs at every treatment or every motivational interviewing session. It's offering advice, and that only occurs if the patients accept the offer. So first up, asking, tell me your story, like looking at those open-ended questions that we use every day. What brings you to PT? How can I help you? What have you been told about this? All great ways to start to get the patient talking. But the most important thing is that we're getting the patient comfortable in articulating their own thoughts about behavior change. We're letting them dig into some of these things a little bit more, and we want to be comfortable with silence with these two. Don't just look to fill the gaps. If you ask the question and they give a short answer, sometimes pausing and letting there be a little bit of uncomfortable silence, they'll start to give you more information. Also want to caution you that not all open-ended questions are beneficial or helpful in motivational interviewing. We think about questions that might create resistance or reinforce reasons against change, like what are some of the advantages of not being fit or not being helpful, might put the patient on the defense. They might feel a little bit attacked, and that's going to kind of close them off, and they're not going to want to continue to give more information or to dive into their motivations if they feel attacked or they don't feel safe. So when reviewing for the home exercise program, after going through your treatment session, you can ask the patient, what are you going to do for homework? What of these exercises that we tried today were really beneficial for you, and what do you think is going to be important for you to do at home versus I want you to do this 3 times a day? Letting the patient kind of come to it on their own, because then they've realized how important the activities that you've done together can be. You can also ask them, how many times a day do you think you need to do these movements? So maybe they were doing some back bends to help centralize their pain, and you can ask them, okay, we've eliminated your pain. How many times a day do you think you need to do that to help you stay out of pain. Digging into what they are going to do if it goes the other way, if it starts to cause them pain, how are they going to problem solve around that? So that way they've already thought through it and they're kind of set up. If it does go that way at home, they're not lost and then they don't do anything till their next treatment session or even cancel their next treatment session because they're in too much pain. And then asking them, how do you want to remember these exercises? Some people learn better with pictures. Some people just want a written list. Some people like to have a video of themselves doing it on their phone. And all of those are good options, but asking them what they feel is best or would be most beneficial, because then again, they're collaborating in their treatment session and they're making that decision on their own. Follow-up visits, we can use open-ended questions. Tell me how things are going. What is working for you so far? What do you feel like you need today? Really asking the patient, because again, they're the expert on their own, on themselves. And so we want to consult with that expert every single treatment session. If you only do it on the first session and then you kind of take the reins and don't bring them in to collaborate on follow-up sessions, we're not really utilizing motivational interviewing to the highest ability. So asking them about what's working, what isn't working, are we on the right path can be really beneficial as well. For affirmations, we want to support the patient as they engage in change talk. We want to encourage the patient to engage into the next step of the process, focusing on their strengths, abilities, or efforts that they've given. And we really want to be genuine. Not all affirmations are helpful in motivational interviewing. Think about a time when someone was like, "You've got this, good job, keep up the good work," and it really didn't feel genuine how you felt when that happened. So sometimes when we affirm the patient's ability to change, especially when they've expressed doubts about their ability to change, that can actually be detrimental. For reflections, we want to reflect on what the patient has told us so far. It really gives the patient evidence that we've been listening to them. We've heard what they have to say. And when we reflect, we really are looking for the patient to respond with a, "Right, yeah, that's exactly how I'm feeling." And that's going to leave the patient more willing to discuss other options for change. When we're reflecting, we can emphasize the patient's change talk and give less prominence to their resistance talk. So if they're like, I don't know if I'll be able to make this commitment or anything like that, we can reflect and really stress more of that change talk to kind of bring that more to the forefront. Again, you want to allow for silence because this can be an opportunity for the patient to continue to elaborate or to give more information. But we really want to make sure we're keeping the conversation moving forward at the same time. For summarize, this is where we're tying together the patient's thoughts, concerns, and feelings. Just a nice little package. And so Dr. Miller had a really great quote. He said that summarizing is like collecting flowers one at a time and then giving them back to the person in a little bouquet. So we're really just taking everything that they've given them and packaging it back up for them. This can help to create a sense that something significant has happened during the treatment session, especially if you spent the treatment session, a lot of the treatment session talking and discussing. Sometimes our patients can leave and feel like, well, what did we do? And so if you've summarized it, it can give them feel like something more significant has happened. And we can help the patient to see how some of the things that they've told us work together. A lot of times patients don't realize that their levels of stress and anxiety can amplify the levels of pain that they're having. And so by summarizing everything you've talked about and some of the situations you've talked through, we can help guide them to realize that a lot of these things work together. Summarizing can provide closure to one line of discussion and allow for that transition to a second line. So after we summarize, asking the patient, did I miss anything? Is there anything else you'd like to tell me? A lot of times, you finish a conversation and the patient has like 6 other things that they've forgotten to tell you, but if we don't give them that opportunity to jump in, then how do we know if there was anything else they wanted to offer. And then that last little piece, offering advice. And remember, this is what you want to ask the permission. Ask the patient for permission before you just give advice. We're resisting that writing reflex that we all have. So when you're going to give an HEP, asking the patient, hey, Linda, would it be okay if I showed you a couple of things that might be able to help you manage your pain, or help you to feel like you could be more mobile, or whatever verbiage you want to use? Would you like a few exercises that you can do at home to address these things? Asking them things like, can I give you some exercises that will, and really tying it back to those goals that you guys established in the focusing portion of the motivational interview. Or saying something like, can I offer up some stretches that will help ease the pain? So that's the end of motivational interviewing. Hopefully you guys are all experts now, but I'll open it up to any questions that you might have.
So I have a question. Do you feel that everybody would respond to motivational interviewing similarly, or do you feel that there's really there's a certain pathology or certain type of patient that would do best, that you found best?
So I don't think everyone responds similarly to motivational interviewing. I think we need to use our clinical judgment and decision making when picking that patient. Some patients, they respond best if you say, listen, Joe, this is what we're going to do, and this is why we're going to do it, and you're going to be feeling great. And that patient loves that confidence, and they want somebody to give them something that's going to make them better. But there's definitely that set of patients that needs to come to it on their own, and they've had PT before, they've done all the exercises, it's never helped, but we really haven't dug into what are their motivations for seeking PT, and what's really going to resonate with them when trying to get them to change their behaviors and be more active or be more fit or do their home exercise program, what have you. So I think it all depends.
Then one other question, do you feel that this information pertains really well to just PT, or do you think it pertains pretty well with medicine, surgery, with occupational therapy, speech therapy?
Yeah, I definitely think it applies across the board. There are books written about how it can be applied in different settings, and motivational interviewing was something that, like we talked about when we were talking about history, was really developed to help problem drinkers. So it wasn't developed for the healthcare setting, but as it started to gain traction, some clinicians started to bring it into healthcare and really discover that it can be really powerful for some patients. And so I think that we can find that it can be applied to, a variety of different facets of healthcare and even outside of healthcare.
Thank you.
You're welcome.
What other questions do you guys have? Feel free to either unmute to ask or type into the chat.